Hello, LinkedIn, and hello, YouTube. We are now live, and we're excited to have this conversation. As a matter of fact, this has been a long time brewing. Nick Bassett is joining us from Intermountain Healthcare, from Castell Health, which is a partnership with Intermountain Healthcare that delivers on value-based and population health initiatives. So we've seen a lot of excitement about this topic. We're excited to have this conversation ourselves. And again, your hosts today from Symphony RM, myself, Chris Hemphill, I work on market-facing data science projects. And Mike Leonard is our CEO. And his background comes from bringing some of the leading edge things that they were doing around next best actions and conversational intelligence from marketing, from the finance world, telecommunications world, and taking those concepts and turning those analytics into actions for healthcare. So really exciting stuff. But while we're getting started, good morning, thank you. But while we're getting started, there's been some major tragedy that's happened over the past week since we spoke. And we just wanted to share some words and thoughts with regards to Jacob Blake and all the things that are happening right now. So, Mike, I wanted to let you have the opportunity to share some thoughts on that.
Yeah, and I'll keep it brief, but it is important. For us at our company, and for me personally, what happened with George Floyd a couple months ago was a real call to action, and we've been striving and working really hard to do better and be better at our company. And right before we got started, I know Nick and the team at Intermountain are as well. While it's early with what happened to Jacob Blake, and I'm sure more facts will come out, the video was appalling. And I think it's a reminder not to let our guard down, not to slow down our efforts and what's happening. We've had a few really valuable outside speakers come and speak to our company and share some of their experiences. So just want to acknowledge that what happened with Jacob Blake is yet another in a long list of tragedies, and something we need to continue to focus on and do better on.
Yeah, thank you for those words, Mike. I was running, but before the incident happened, I was running at night on Atlanta's Beltline and witnessed a domestic violence incident. I saw a couple fighting, and I was thinking through my options, the possibility of going and trying to calm the situation down and de-escalate. But the first thing that came to my mind was potentially being in a dangerous situation once police officers rolled in and potentially being a victim of another attack like that. So instead of intervening or helping, I ran a little bit further down the street and called the police officers from a distance. But after that incident happened, the incident happened about 2 days after that run. And it just made me think about, how that decision is kind of, it's the violence that's happening at that level is hitting me at a place where I'm actually, scared to intervene and help people in these scenarios. So it's attacking that the attack is kind of going deeper than just what we're seeing on TV, and it's affecting how we interact with each other. So thank you for being willing to share those thoughts, Mike, and we'll continue updating. Thank you for encouraging that in our culture. But on the subject of population health, just going to our topic at hand, we're really excited again for. Thank you, Henry. Yeah, absolutely, and thank you, John and Terry for hello as well. But to the topic at hand on population health, Nick. He's passionate about this. When we first spoke with him, he said that he would be happy to evangelize the subject of value-based care and population health. I don't know if you popped over to his LinkedIn, but this is what he has lived and breathed for more than 10 years. So a long history, starting out in the analytics side and then moving into various leadership roles and working with different groups within the organization. Within Intermountain Healthcare, and now within Castell's value-based care. Castell is the value-based care arm. So, Nick, what we're excited about is just the fact that you've lived and breathed this. You've seen some of the challenges, and you're able to look at a lot of the things that are happening today. And I think that what the audience is excited about is being able to have a discussion with you on what has what's worked, what hasn't worked, what red flags to look out for, what metrics to use to look at success. But then when we go all the way back, when we say value-based care, population health, risk-based contracts, it means so many different things to many different people. So just to level set, make sure that we're all talking and thinking on from the same page. Could you define these concepts for us around value, like what is value-based care, population health?
Yeah, and good morning, everyone. Really nice to be on with you. And Mike, Leonard and I have been good friends for a long time, so it's an honor for me to join this conversation. I'm just getting to know Chris here this morning, and just a phenomenal individual. So really appreciate you letting me take some time. You're right. I actually entered healthcare, began my career in healthcare back in 2008, and you'll recall at that time, there was some pretty significant economic kind of crises going on. And I think it's fair to say that that's really when healthcare hit center stage in a way that it hadn't before on the political agenda, in local communities, urban, rural, et cetera. And people really started talking seriously about the cost of healthcare is way too high, and we've got to figure out how to rein this thing in. And from almost literally my first day on the job, my interest was piqued, right? And I wanted to be part of that solution. Fast forward here 10 years, I think, even just back to kind of these very appropriate introductory comments about what we see even with equity across the country. I think what we're seeing is that when we talk about population health, and I'll make a distinction here, at least as I see it, but as we talk about population health, it's really that. It's how do we appropriately care for and support the populations that surround us. And I think you really need to begin to factor in with population health the conversation around social determinants of health and equity, and all of these things come together in a way to say, are we able to appropriately provide medical care and really help move individuals towards health in our communities? So when I think about population health, I think it really encompasses all of that. When we think about value-based care, though, I think value-based care is a term that in my mind, I begin to bring more of the payer angle into this, or the insurance company angle into this. And understanding how is it that we as a country or as communities pay for the care that is received, and ultimately what is the incentive, what is the economic financial incentive to do certain behaviors. I think the word value in there is so critical. I think forever, for a very long time, the notion of what is the cost of care was kind of out of the picture. It was actually really kind of taboo or inappropriate for a provider to ask a question about, how much does this cost, or how much does that cost? And I think we've really seen that conversation change in a way that we're recognizing our consumers care about the cost. And if we don't care about the cost, we're going to see things drive up. So when we talk about value-based care, it really begins to get to what is the arrangement between the provider and the insurance company, and what are the economic incentives tied to that relationship. So there's a couple thoughts.
Nick, can I ask, one of the things that often inspires me about value-based care is, the way the system is traditionally set up is that you have your payer who wants you to spend less money. Mm-hmm. And at least it feels to a lot of patients like they just want them to stop consuming care. Right? On the other hand, you have a provider who doesn't necessarily want you to consume care, but has a financial incentive for you to consume care. Mm-hmm. And so, if you become diabetic, right, unfortunately, the payer starts losing money and the provider starts making money. One aspect of value-based care is it tries to align the incentives so that actually payer, provider, and patient are all better financially if patient stays healthy. Can you talk about, is that how you think about it? And can you talk about how that impacts what you guys do at Intermountain, Castell, and Select Health?
Yeah, absolutely. And I think you said that really well, Mike. I think the aha that I had early in my career that really influenced kind of what I wanted to commit my time and talents to was the day that what you described kind of came clear, into my view that, my revenue line on the provider side is all about people being sick, right? In a fee-for-service world, that's how the motor runs, right? I mean, you need that top line revenue for people to be sick. And so, as Intermountain Healthcare, I mean, again, going all the way back, to that point in time, a lot of discussion around how can we be better? How can we make this about patients? How can we make care more accessible, affordable, et cetera? One thing that Intermountain and many large many systems across the country have as an advantage is we actually own a health plan. So we own a health insurance company here in Utah called Select Health, and they've done a phenomenal job really, creating good products and things. But we stepped back as an organization and said, even in our own house, how can we begin to make changes that get the incentive right? That get it so that our providers are actually the ones driving the conversation around what care is appropriate and what care is not, as opposed to an insurance company kind of, making those decisions. And so, it started with us looking internally at what I would call our funds flow. So because we owned Select Health, how did that business operate? But how was that connected to our hospitals and our medical group? And that's fueled, again, what I would consider a decade-long conversation about how do we get better internally with this. As we've moved down that journey, just kind of by way of a little context here with Castell, we recognize that while we can do a lot of good internally with our own health plan, that this isn't a single health plan solution. This is a countrywide problem, and that in our communities we knew this had to be something that could be done at a multi-payer, multi-provider level. And that's really why Intermountain, chose to create Castell, a separate entity to really go out and be able to enter into those multi-payer, multi-provider arrangements to continue to work on how do we get this right? How do we enable providers to do what they went to medical school to do, and that is care for patients and help them, get better.
Go ahead, Chris.
I was just going to, well, go ahead, because I had kind of the next question in mind.
Well, what you said right there about providers, I want to scratch at a little bit, because population health is obviously it's a great concept. I don't think anybody could argue against value-based care or population health, except when you start to look at where the rubber meets the road, right? It's the provider whose role and job has to change each day. Mm-hmm. And at a lot of places, right, population health is done as the EMR now kicks out a bunch of registries, and we're going to forward those to the primary care providers. And by the way, we just added 10 metrics to how you guys are performing in your role.
Yeah.
So can you talk about, obviously Castell is trying to figure that out. Can you talk about the impact on the provider of population health?
Again, Mike, I think you said that really well. One of the reasons I think adoption of population health and value-based care has maybe been slower than we initially thought 5 or 6 years ago is because of exactly what you just said. We've got clinics and hospitals that are built to be fee-for-service engines. That's how they're staffed. That's how their workflows happen, right? And it just is what it is. And groups, clinics, especially small clinics, which represent, the lion's share of the medical care that we're receiving, or certainly a large portion of it, they don't have resources to take a registry, as you say, or take that patient list and really know what to do with it in a meaningful way. And so that's and you call that out really well. It's another and really a core part of what Castell is doing is we're basically taking those functions that don't exist in most clinics and creating essentially a resource to go in and help these providers be successful at it. And in terms of kind of what that looks like, and I think we'll get into this a little bit here, but certainly the data and reporting is foundational to that, right? And I think we'll take some time a little later on here to dig into that. But I think it's also enabling top of license work for folks, and that you really don't want or need your provider to be doing some of the things that are really, really critical in population health and value-based care. And so we've one of the kind of the core central, we think of it as our nerve center in Castell, is an army of care guides, folks that are actually non-clinical. But these are folks who know how to interact with people, know how to be engaging, know how to encourage them, nudge them in a way that will enable them to get better care. These are former bartenders and folks that do that type of work, and so that's really what we've been experimenting with and seeing some really encouraging results in terms of supporting those clinics in their efforts.
So we got an interesting question in the audience, basically about the efforts that smaller clinics might be able to take with regards to addressing population health issues. Wondering just your thoughts on what smaller organizations can do, or what systems might need to be in play to help these smaller organizations be able to play on this as well.
That's such a great point, and such an important question. As we in Castell have been out kind of interacting with groups and helping support this transition towards value, this point has become abundantly clear that you've got some large groups that, as we interact with them, their response is, hey, we've already got this, and we've got this, and we've got this. And there may be a couple pieces that we're able to kind of step in and help support them with. When we sit down with smaller groups, their reaction is, no, we don't have that. I've got the same person, answering the phone and scrubbing the toilets at night, sort of thing, right? No, yet I do not have extended resource. And so one of the things that we found to be a really critical part of this is, how do we leverage technology? How do we allow people to, frankly, work remotely? And so we'll have, back to my care guide example, we'll have a care guide that can kind of remotely support a clinic, a very small clinic, with 25% of their time, meaning that they're ultimately supporting 3 or 4 clinics, calling into morning huddles, right, with the clinic, et cetera, to help kind of provide that support. But it doesn't have to be a full-time, really heavy investment. It can be what's needed for the size of the clinic, and still be really successful.
Thank you. And earlier you had mentioned that data and reporting were foundational to these efforts. Could you elaborate a little bit more about how data is being used, what you consider data versus information, ultimately, what role data plays in the transition to this process?
Early on when I started in pop health, I sat with a number of organizations, and the conversation was always around, if we had the data, someday, if we had the data, it was kind of always this, we don't have the information. It was 5 or 6 years ago. And then one day I was sitting in a meeting, and I realized that the conversation had flipped. And all of a sudden, we'd actually done a really nice job, going out. And as we think about claims data, or we think about, ADT feeds, or obviously clinical data, et cetera, all of a sudden, I think that our industry had evolved to a point that we had data, and the conversation was suddenly, we have so much data. What do we do with this? How do we possibly boil this down to a provider or to a clinician or something that they can do anything with, right? I mean, I've got data coming out my nose, but what do I do with it? And I think that's really been our journey for the last couple of years, is taking that information, as you call it, that's just huge amounts of big data, and really boiling it down into what is that next best action. Mike and I have had a lot of conversations about that. What is the right thing to do right now for the patient that I'm interacting with? And while I'm not sure we've solved that problem, I'm really encouraged by some of the tools and reports that I see coming out of best-in-class, vendors that are really invested in how do we take all of these disparate data sources and create a really meaningful interaction with patients as a result of that. So a couple thoughts, and yeah, we can go deeper on specifics if you'd like, but that's certainly the way I think about it.
Nick, let me just push you a little bit, because you said some things there that I thought were really powerful, but let me ask you to expand. You talked about, hey, bartenders may be great for healthcare if we can help influence behavior, right? So there's a challenge influence behavior. You talked about care guides helping scale the business and more efficient use of the primary care doctor's time. Let me just maybe ask you a numbers question, and I'm going to make up numbers that you can fix. If in a fee-for-service world, a primary care doctor has a population of 2,500 to 3,000 patients, could be more, could be less. In a value-based care world, you can argue that same primary care-based doctor may need to cover more people, right? And if he's got to cover more people, that's less time per person. But now he's responsible for keeping all of them healthy, not just addressing the slight few who may be chronic or acute in this moment. So we've kind of multiplied his work, by 2 load factors there.
Yeah.
How do we scale the ability of the health system to engage people as we change the conversation to be more about their health in addition about their sickness, right? Hey, smoking cessation. Hey, eat better food. Hey, how do we do all those things? And how can digital help?
Yeah. That again, really, really good question. We, I like to think about a primary care provider as the CEO of a multi-million-dollar company, right? So, right. I mean, so however large or small that panel size is, I think 3,000 is probably on the larger end in some cases, but however big it is, right? They are accountable for all of, especially in a value-based environment, that primary care provider is accountable to some degree for how much or how we spend those dollars, right? And I think I think there's 2 fundamentally important things that are happening right now that are going to change kind of how the interaction occurs with patients. The first is what you've already heard me talk about a little bit, and that is making sure we're building the right, what I'll call ancillary resources. Maybe that's not the right word, but yeah, the care guides or support when a patient's in a skilled nursing facility, right? And how do we get eyes on that patient and still support that patient, even though they're not, in front of our primary care provider. So whatever those resources may be, really getting those right. And then I think the second piece of it is a little bit of a paradigm shift for our providers, and realizing that what they need to be focused on is caring for the patients who need an MD, right? Caring for them, prescribing medications, and creating a care plan that is specific to their needs. But beyond that, frankly, probably relatively small number within their 3,000, patient panel or 2,000 patient panel. They've got a whole team of people focused on, that should be focused on wellness and things like equity, that, we've been talking about social determinants of health, someone that doesn't, have an air conditioner in their home and they live in the South and it's, 100% humidity and 100 degrees outside, right? I mean, those all complicate health factors, but that shouldn't be something the physician themselves is trying to kind of think through and manage. They've got a team to help them really be the CEO of that company and really enabling our providers to function that way.
Fantastic. So Mike, we got a question from Jean on with regards to Symphony, Castell specific initiatives and goals. Just wondering, Nick, your perspectives and thoughts on Symphony's relationship and any quantifiable outcomes that you've seen from that relationship.
Actually, maybe let me intervene on that one, Chris. I think I'd love to not make this about Symphony RM. I'd love to keep this about population health generally. So maybe just erase, Nick, the words Symphony RM. Ask, how without naming people, how are vendors helping Intermountain? What are the things that people can do to help you?
Yeah, how about I'll start with Symphony and then we'll leave the rest nameless, and how they've been great partners. And I think it'll be a nice carryover from the comments I was just making. One of the most important things that we are focused in Castell, back to my comment around kind of a paradigm shift for these physicians is how do we get out and do that education and interact with these physicians and these clinics in a way that helps bring them along. And actually, our particular relationship with Symphony RM has been tools and resources that are helping provide that insight and give that data to the teams that are out working with clinics. And so, that's certainly something we're very focused on, even down to some really tactical metrics like how many clinics, how many providers, right? Tracking visits, our visits with them is certainly kind of a really tactical priority. As we think then kind of more broadly, though, around the care that's being provided, I'm not sure that we have fundamentally different metrics than I think many in this space, which is we are literally watching every day our inpatient admissions, our ED admissions, our surgery, per thousand rates, things like that, and really dialing in on where do we see opportunities coming up. We've had just an amazing analytics team who we've had an analytics partner that we've been partnering with, but in addition to that relationship, we've just had a phenomenal analytics team that's been doing some really cool work around. They use what are called the Western Electric rules. I'm getting way out of my league here, but to essentially look at when is there variation such that it's worthy of kind of responding and doing something, as opposed to just looking at a number every day. Oh, or IPK is this. And that's actually been a really exciting advancement for us in terms of knowing which single points to pull out and go dig into and understand, and had some really, frankly, cool, inspiring stories come out of what that's helped trigger for us in terms of outreaching to patients that really needed support. So
one thing I would add, and I know you guys do some of this, Nick, I do think in the fee-for-service world, if you think about that triangle of the chronic and acute, 5% of us consume 50% of the care, 8% of us consume 80%, depending on where you are. Most health systems are focused up there, but in a value-based care world, you have to own the whole pyramid. The 5% who are going to be chronic and acute, the 20% who are rising risk, and the 75% who are otherwise healthy. And so I think it's important in a value-based care population health world that you challenge yourself to say, I need to have an engagement plan for every single person in that pyramid, every single person. And if I don't, there's something I'm missing, right? And the engagement plan could be as simple as I need to get them to log into, the portal to read their own lab results, be engaged in their care. I need to get them to renew and make sure they stay with me at the end of the year and they're loyal. So I think that's a really big deal. And that if you do that, we've talked a little bit about unlocking dollars and showing the value of some of the, I'm just going to use your word because I think it's funny but powerful, the bartenders, right? That we could show the value of the bartenders if we can show that they can help engage people in these valuable behaviors. Nick, we did get a question though that I really liked from Kathy Rhodes about how do you show the ROI? There it is. How do you show the ROI on some of those case managers? Because that's how you unlock your ability to invest in them. How do you guys do that?
So again, as I sit with groups discussing pop health, frankly, all across the country, this question comes up everywhere that I go. And I have a couple of thoughts. One, it is tough. There's not a silver bullet. There's not a single right answer. There's not a formula we've created that really answers the question, especially for those that are in large integrated systems. So I guess I would start there that this is a very robust conversation happening all across the country. As we've looked about it, or as we've looked at this though, and the approach that we've taken at Intermountain and with Castell is to do what we're doing, which is we're aggregating all of the assets and resources, and maybe all is probably a little strong, but a large portion of the assets and resources that may not generate fee-for-service revenue, right? Or certainly, Clara, if I were to pick on one example here, so we have a team of nurse practitioners and APPs that are out in skilled nursing facilities, right? Our post-acute care team. And when you look at kind of the revenue they generate as opposed to the expense, just in that framework, there certainly is not ROI, right? There would be no business, no one from a venture capitalist, no venture capitalists are coming and building that service from a fee-for-service perspective. But as we look at it in the context of our broader risk arrangements, that's where it fits. And so we're not actually justifying on a really piecemeal basis each individual FTE or each individual service line, as much as we're monitoring the performance metrics. So if I stick with this post-acute care example, we're very focused on, how many patients are going to SNF, what is the length of stay in the SNF, and what's the quality of care that they're getting in the SNF. And we know that when we focus on those things, we get through our value-based contracts, right? We're benefiting on the back end. And so having those resources pooled together the way we have, again, not just post-acute care, but all of this stuff, the care coordinators and to some extent care managers, et cetera, having those in a single pool where the revenue stream coming in as a result of their collective work to manage the population, that's been a big step forward for us. Again, not sure it's the answer, but it's been a big step forward for us in that question.
One of the other things I've seen people do around the country, Nick, is I'm just going to give two examples with some specific numbers to make them real. One group I saw, they were focused on driving down readmissions, and they had a program that they knew that if you were discharged, and I forget, I think it was CHF and COPD, if you had two chronic conditions, that you were 17% likely to come back. But they also knew if they could get you to a follow-up PCP visit and 2 nurse phone calls in the first 30 days, that your readmission rate dropped to something like 2%, right? It was staggering. But they also knew they had a really hard time doing those things, making those things happen. But when they sat down and they were able to put dollars to it, they said, okay, well, if we drop our readmission rate by X, then that saves us this much money. And so really the value of doing those 3 things is it drops an individual's readmission probability by 10%. The readmission would otherwise cost us $15,000. So it's worth $1,500 presumably to do these things. Right. And then they assigned actions. So what they said was the value of the bartender getting Chris to show up at his primary care doctor within 48 hours of discharge, and then getting him to take 2 phone calls with the nurse to follow up, that's $1,500. Yeah. And as long as the bartenders are getting that done, man, we can invest in more bartenders.
Yeah.
And another one is pre-diabetics. A lot of people know if we can stave off a pre-diabetic going diabetic, it saves us $1,500 a year. So if we can find bartenders who do that, then that's dollars to invest.
Yeah. Mike, the complicated piece about what you just described in a large kind of integrated system for those that are in this space, is you're going to have 3 parts of the organization who are all going to come and say, hey, we'll reduce readmissions by 10%. And here's how we, and here's the ROI on that. And so just using your example to kind of bring back to that point that I was making is for us to bring and pool those resources together really help streamline the message of where the investment was made, so that we didn't have this team and that group all going and requesting funding and all saying they were going to reduce readmissions by 10%, but saying, hey, the resources and assets to reduce readmissions by 10%, they're all here, right? And that's what they're focused on. And so anyways, really spot on comment, and hopefully that brings those 2 thoughts together for folks.
Yeah. And thanks for I love the back and forth with that analogy. And I also want to just thank everybody for staying on a little bit extra with us. I know that we were supposed to end at the top of the hour, that we were supposed to solve all the problems within 30 minutes, but I think it's a little bit bigger than that. So we got a very good question that came in from Colin Hung, and there's a little bit of discussion going on about it, which is when physicians run into social determinants of health challenges with people that need care, what are some avenues that they can turn to? What are some, like with health equity as kind of the guiding light? What are some avenues that are available to help with social determinants of health challenges?
So this has been something we've been exploring here in the state of Utah for a couple of years now. And I think part of why it's such a great question is because the answer is terribly complex, meaning it's not something that a physician or a clinic, or frankly, even a large integrated delivery system like Intermountain Healthcare is, no one of those is the answer to this question, right? Because what you begin to introduce is all sorts of community programs and local governments and kind of their role in how do we address the social issues. And so, just as one specific example, a couple of years ago, Intermountain Healthcare put forward an investment in a partnership with the state of Utah in a program we call the Alliance on the Social Determinants of Health. And what we've been really experimenting with and are seeing some good results, and I think still, yet lots to learn, is what do those partnerships look like? How do we get one of our medical group clinics, for example, to really pull on local community resources and assets to solve these problems? And historically, there really hasn't been a very good connection point to do that, right? There isn't a robust way where they can input an order for Meals on Wheels, right? Necessarily. I mean, that's not kind of a standard drop down in their EMR of, hey, this is what the provider needs. And even if there were, it didn't trigger an order to Meals on Wheels, just as an example. And so, there are several kind of vendors out in the space right now that are experimenting with it. And I think we've come a long way, even in the last 2 years, in how do we bridge that gap? I mean, the organization that comes to mind that I know is kind of a forward thinker is called Unite Us. That was really about connecting all of these services and connecting them in with clinical workflows. And so, again, definitely not a simple question or a simple answer, but we're seeing a lot of movement in that space, and it's certainly really critical for what many of our patients are struggling with.
And that's really, really powerful too, to start addressing, especially when a lot of people go into practice because they want to address those issues and help those communities. So it is powerful to start looking at ways to impact that. Now, we've only got a couple of minutes left. Oh, Mike, were you about to say something?
Well, I was going to ask, given that we're almost a couple minutes, Chris, and you can overrun me here, but Nick, I'd love to go back to the beginning of this conversation and maybe ask you, because you made some powerful comments before we hopped on, thinking about addressing equity in the community. We've talked about how data is critical to delivering population health. I think you made a powerful distinction between data and information. And Chris, before we hopped on, pointed out a lot of our customers are starting to use AI and machine learning that we work with them on. The challenge is, as you move further away from the data, people don't realize sometimes the equity and biases that get assumed in the data. Can you talk about how you guys think about that, and how not just it helps you undo the bias, but how it helps you be better, right? Better care, and actually, I think financially helps you perform better if you do it right.
Yeah. So thanks, Mike. And such an important topic, obviously, especially at this time. We're pretty early in some of the things we're specifically doing, but let me tell you about the conversation that we're having. In fact, just yesterday, I was in a presentation that was a little bit of an overview of a book that we were talking about before we jumped on, called Weapons of Math Destruction, which is really exploring the fact that, we kind of lean on, probably more than many of us realize, AI and predictive analytics to help us do what we do in all sorts of ways, right? Even when you go to your Google search bar and start typing things in, right? Those things are all triggered by algorithms kind of running behind the scenes, trying to kind of nudge in one way or another. And the conversation that we're having is centers on two things. One, that designing for equity needs to be intentional, right? It's not going to just happen. It's not just going to fall into place. It's got to be a very intentional, deliberate conversation and effort. And so we're stepping back as a leadership team and asking ourselves, what does that mean? And then the second piece to that is not just that we need to design intentionally, but that we have got to be abundantly aware of how do our data algorithms work, and are they proliferating a problem, or are they accounting for the fact that there's a problem? and really kind of digging into, what are the outcomes of the data and the tools and reporting that we're using. And so, again, really robust dialogue happening right now. We're excited about kind of the conversation and where we're headed, and I think more to come. So.
All right. Well, thank you again. And I think we have time for one more question. And I'm going to combine two questions that were asked into that one question. So Jared Carter and Henry Soderberg, they had a similar question. Jared asked about wellness and prevention models that have been shown to display measurable change in healthcare costs, whereas Henry was more focused on data and analytics and the insights that were able to be derived from that. So I think that's a great opportunity to take potentially a prevention model or a wellness model and say, hey, quantifiably, here's how we impacted cost. Just curious your thoughts on that.
Yeah, I think, just back to the ROI kind of conversation, I think we're getting better at it, especially in some really specific places. So as we think about wellness and prevention models, one example that we've seen, at least in our organization, is a really focused effort we've had on pre-diabetes and obesity. And we've actually had kind of internally with our own caregivers, employees, a really fun, maybe fun's not the right word, but it's been really encouraging, really promising results from individuals that have embraced this program and really lost a lot of weight, and their lives are changing, right? And it's almost impossible to quantify the impact of that, right? That you've got more motivated individuals, more productive individuals, and on and on and on. But I think Jared's point is spot on, that we are getting better and better at how do we do that? How do we kind of isolate a program and an intervention and really unpack the downstream outcome? And the thing that we have to always remember, and it gets back to the point that I was making, is that any one of these interventions is not, it's not a siloed independent thing. There are always multiple factors associated with someone's health and well-being. But really, I would echo, we are getting better at understanding how those interventions directly do result in changes in someone's health. So,
I'll just flag it. One at Intermountain you didn't mention, but I know you work with too. The kidney services team at Intermountain is doing some great work and using artificial intelligence to predict who in the population has kidney disease but may not know it. And so you guys know how prevalent it is. The National Institute of Health came out and said 50% of people being born right now will reach stage 3 kidney disease before they die. And stage 3, stage 4, stage 5 kidney disease are obviously incredibly expensive. And so if you can estimate, here's a group that's probably stage 2 or 3 doesn't know it, and we intervene, the dollars that I've seen the team at Intermountain reach into hundreds of millions of dollars of savings if we can stave off kidney disease progression.
Yeah, it's a great example. Thanks, Mike.
Well, Chris,
I do have to say I really appreciate everybody sticking around with us. This has been a fantastic conversation, Nick. We really appreciate it, and it was great to hear about the things that you guys are doing and how all these different initiatives tie together to help solve social determinants and health equity challenges. Really exciting stuff there. We have a couple of conversations coming up next week, folks. We'll be digging into the patient experience that One Medical offers through some research that we've done using natural language processing and AI. So that's coming up on Wednesday. And on Friday, we'll be having a conversation with the Chief Information Officer at Asante. Great things that he's done recently. You can look up Dr. Lee David Milligan and hear some fantastic interviews about some things that they've done really fast in response to the pandemic. But again, we appreciate you, Nick. Mike, thanks for co-hosting, and thank you everybody for sticking around with us, sharing your comments, your likes, your reactions, everything like that. We really appreciate it. Thank you.
Thanks, Nick.
My pleasure. Thanks, everyone. Nice to be on.
Bye, guys.